President Obama has made it clear that his goal is for very significant healthcare reform and for it to happen very quickly. He said he'd like to have a bill done by this year. And key to that reform will be our ability to reduce healthcare spending so that we can expand coverage to cover all. What is wonderful about the initiatives we're going to share with you today is that they have the virtue of both reducing healthcare spending and improving patient outcomes. It's why we are so excited about this strategy. It's why we think it has to be part of the national dialogue. It's why we're delighted to be able to share it with you today, because we do think it accomplishes the goals we are all most interested in accomplishing. We have a distinguished panel with us today who are going to share the specific work that they're doing so you can understand how this process works and how it is we can make a fundamental difference in healthcare reform. And whether you're with us today here in this room, in the overflow room, or on the webcast, we look forward to your participation in the dialogue. We've asked the speakers to speak for about 15 minutes each so that you get enough substance about what it is that each program is doing so you really do understand it, but to also enable us to have enough time at the end to have at least a half an hour for interaction with the audience. If you're here in this room or if you're in the overflow room, we have for you in your packets these little slips of paper where you can write a question, and we will be circulating throughout the auditoriums to collect your questions, and I'll be moderating the panel later today and share those questions with our panelists. All of the panelists have also agreed to stay around for a little bit at the end of the session if you don't get your question answered or if you want to go into more depth on one point. I know they'll be happy to address those issues. And for those questions that we don't get to, and even for those we do, it is our plan to put them up on our website so you can see the written answers as well. Just a logistics reminder, please do turn off your cell phones. We are broadcasting this session, and we want to make sure that folks can hear it and they don't get interrupted with the noise of the cell phones. And also, in your packets, on the left side of your packet, just after the agenda, you have the biographies of the speakers. We're not going to spend time today going through those biographies. If you're watching this on the webcast, those biographies are also up on the chrt.org website, and you can download them. So please do, when you have a chance. All of their biographies are distinguished, and we're delighted to share them with you today. So please do take an opportunity to take a look at the backgrounds of those who are speaking, but we'll simply let you know which person is up and not go through that background for you. So welcome, enjoy. It'll be a great session and lots of opportunity for interaction. And with that introduction, I am happy to turn it over to Dr. Tom Simmer, Chief Medical Officer at Blue Cross and Blue Shield of Michigan.
Thank you. I wanted to provide about 5 minutes of context for the entire discussion. Today we're talking about statewide collaborative improvement initiatives. And this is a major component of a much larger effort to support the creation of a truly high-performing healthcare delivery system in the state of Michigan. Among the more prominent reasons of why we haven't quite achieved that, and I think this is part of the national debate, why is it when we really apply so many resources and we have so much of the talent in the country directed toward delivering healthcare services, why have we in this country not been able to reach our potential of a high-performing healthcare system? And I would submit here's a few of the major reasons. It's not a complete picture, but the first is we really haven't taken a full population focus. I know many of you are from the School of Public Health, and you realize that delivering excellent care to each individual who presents for care does not necessarily result in achieving public health or population-based goals for the healthcare delivery system. And so we need to adjust that and create a population focus. Next, we realize that the delivery system in healthcare really has the components of cottage industry. And I've placed in red the ones that I think are really addressed in many ways by these collaborative improvement initiatives. Physician practices and other centers of care are disconnected from one another, and there have been very few ways where these individual practice sites and units can get together and actually create a learning experience that would otherwise require a more coherent design to healthcare delivery. And I think you'll see that these collaborative improvement initiatives connect otherwise disconnected organizations of care for purposes of improving care, and that creates a synergy that allows improvement to occur that would not otherwise be at all possible. Next, we have a lack of focus on healthcare processes. It's hard to imagine, but when we at Blue Cross have worked on the patient-centered medical home and gone into so many physician practices, the idea that the processes involved in care are tightly managed and well-designed is really not been the case. And I think that what you'll see in many of these collaboratives as well is an attention to knowing more about the process of care and what elements within that process of care are important to achieving better outcomes of care. Next, we have a weak primary care foundation, and while that's not addressed by these specific sets of initiatives, I think it's still an important component of why we have not succeeded in developing that high-performing healthcare system. The next may be surprising to you, it certainly was to me, and that is it's astounding what a dearth of clinical data sets exist to actually track and know how well we are performing and creating better healthcare outcomes. So how do we know that the patients who are getting a hip replacement actually are able to be pain-free and achieve their goals for mobility? Those are not found in claims-based data sets or others, and we have not really created these clinical data sets. Well, I think you'll see in these collaborative improvement initiatives that each of them relies on the development of a very strong clinical data set that's key to improving patient care. And finally, we have had poorly aligned incentives. And while it's true that these programs are not part of an incentive program, it is true that when you need to make investments on the healthcare delivery side to improve care, those investments do have to have a business case. And unfortunately, the manner in which payment occurs has not been very good in creating the business case to improve quality. And that's something that I think these programs will lead to a broader recognition of how we as payers need to do a better job of creating the business case for quality improvement. I have provided more slides that I won't actually be talking about, getting into a little bit of each of these components with just a little bit more information than what I've given today. But I think it's worth thinking about how these process improvement efforts actually relate to the broader goal of achieving a high-performing healthcare delivery system within the state of Michigan. And as my final slide, this is a website that includes more information about these value partnership programs and other partnership programs that exist in this same vein. So thank you. With that, I will turn the microphone over to Dr. David Scher, who's our next presenter.
Hello. I hope you can see me. I can't really see you with these lights. I'm going to do two things that I don't normally do in presentations. See how they work. The first is use a cartoon. I've never used a cartoon before. This cartoon says, for those of you who can't read it, some obviously can, these new regulations will fundamentally change the way we get around them. And I was so excited by this because it really captures in just a few words the paradigm that we're operating in which various stakeholders in the healthcare system are trying to outsmart each other. And incredible amounts of creative energies are devoted to that challenge. What I want to impress upon you is that the projects you're going to hear about today fundamentally change that set of relationships. And the full measure of the creative energies of the physicians and allied health providers and the hospitals involved in these projects are devoted entirely to rigorous self-assessment and quality improvement. And it's a radical transformation from standard practice. The other thing I'm going to do is use some superlatives. I try and avoid that because I tend to focus on the work that lays ahead of us rather than on our accomplishments. But I really believe fundamentally that you're hearing about projects that are extraordinary, that they represent transformational efforts. They aren't just a set of interesting projects that accomplish some good works. We're talking about healthcare providers, doctors and their team members truly fully owning responsibility for assessing and improving the quality of care without any barriers, but in fact with quite a few supports and a good bit of assistance from other stakeholders in the system. And I hope you'll come to understand that in the few minutes that I'm going to spend speaking to you. What these folks are doing is relying, as Tom was saying, not on a paucity of data, but on comprehensive, robust clinical data with in common registries that are available to them from cases all across the state, not just Blue Cross cases, but cases from all patients, from all payers, and from those who aren't insured. And those data include information about patient risk and process of care and outcomes of care, and they're pooled from across institutions around the state. And the coordinating centers, who will be represented by their clinical champions today from 3 of the projects, are responsible for doing robust clinical analysis to examine the link between process and outcome of care and generate new knowledge about those relationships, and then work with their peers throughout Michigan to harness that new knowledge in really sophisticated, systematic quality improvement efforts. I think this is unprecedented. I think it's groundbreaking, and I'm incredibly excited about it. Fundamentally, we're making great strides in creating systems of care that are self-optimizing, which is something we've talked about for a long time, but I don't think we've done until now. Another important attribute of these projects, which differentiates them from other activities in healthcare, is that this is accomplished through collaboration, not through competition. And it's accomplished with the providers taking the responsibility themselves without self-reporting, without judgment by third parties. And their accomplishments, I think, exceed what you are used to seeing in other arenas. So now I have an exciting animated slide that I'm using to describe the context, which is what we call our value partnership programs at Blue Cross. We have hospital programs, and we do have a hospital incentive program, and these collaborative quality initiatives do fit within that program. We have physician incentive programs. The heading for that is the Physician Group Incentive Program. And in the center, when there's overlap, because there are doctors and hospitals involved in these collaborative initiatives, we have our collaborative quality initiatives. I won't read these to you, but these are the projects that are active now. And at the bottom, we reference the Keystone projects, and I see we have some MHA colleagues here who are actively involved in leading those. And those are sister projects which have many commonalities to the collaborative quality initiatives that we'll be talking about today. We do have 2 CQI projects that are more outpatient focused, one on using lean thinking management technique to redesign and re-engineer outpatient practice, and in a collaborative way across physician organizations throughout the state, and another that's just getting off the ground on organized anticoagulation services. So why did we begin this journey? We recognized a little over, I guess in 1996 it was, so over a decade ago, that simple performance measures which folks were relying on didn't address most areas of care within the hospital setting, which are often highly technical, rapidly evolving, and associated with scientific uncertainty. And the work of the Northern New England Cardiovascular Disease Study Group on cardiac surgery, which basically created the model on which these programs are based, demonstrated that it was possible by pooling data across centers to get well beyond the pretty meager performance indicators, lowest common denominator type indicators that everybody winds up using over and over again, which have value but shine a narrow spotlight on care. We believe these shine much more of a floodlight on quality issues. A fundamental concept here is that cross-institutional collaboration yields more than competition when we're focused on improving quality. That's because there's a lot more variation across institutions than there is within an institution. So if you're only studying the work within your own center, your eyes won't be open to other approaches that really achieve good outcomes with which you're not familiar. Also, oftentimes, fortunately, complications of care are relatively infrequent even for highly complex and technical services. And so you can't pool enough data to do rigorous scientific analysis when you're just looking at your own data. But by pooling data across the state, the picture comes into focus with pretty rigorous analytic methods. I'm just going to run through some simple ideas that outline the essential attributes of these quality improvement programs. We've already made reference to the need for comprehensive clinical data with robust analytic methods, including sophisticated risk adjustment for mortality and non-fatal outcomes. A coordinating center is an essential feature, and you'll be hearing from 3 of the directors of CQI projects and their coordinating centers. And they're responsible for assuring rigorous cross-institutional examination of practice patterns, identification of best practices, and the coordination of quality improvement intervention efforts across the participating centers. They're also responsible for assuring the data validity, and so they work with the centers, including going out and auditing the accuracy and completeness of the data that are contributed to the registry, which is something that hasn't been accomplished anywhere else to my knowledge other than in Michigan, and assures the credibility and validity of the data that are used to generate some new knowledge and better understanding about what works in these areas of practice. Health plan support has been essential because this is a costly effort, relatively speaking. And then another essential element is aggregate provider accountability for assuring healthcare quality. So the Blue Cross plan here is not making judgments, is not looking at the data. We don't own the data. We don't have access to it. All we want to see is that on a collective basis across the state, that the population experience is improving. And some anecdotes, blinded, not identified, demonstrating how that's accomplished. We believe that that's the most important thing, because it shows that the level of practice and the outcomes for patients are being raised across the board for everybody. We aren't just focusing on a few best providers. Blue Cross does have an essential role. We convene competing hospitals that otherwise would not come together without us providing a neutral ground for that purpose and some encouragement. We catalyze that participation in a positive, constructive way, but I think at this point we've achieved such trust through these collaborations, through these partnerships, that folks are now pretty eager to be involved. They no longer have to overcome the distrust that existed about a decade ago. And then we provide resources which are absolutely essential for the data gathering, analysis, and the orchestration of the quality improvement efforts. Our leverage was key. It really was essential to convening these folks. People didn't trust the Blues initially. They didn't trust the University of Michigan initially. People thought, well, gee, those U of M academics, they just want our data. They have their own intellectual and academic interests. But we've gotten way beyond that, and there is a sense of being in it together. The guns are left at the door, and people recognize that collaboration actually advances their interests and purposes much more so than competition. We have demonstrated that when people have procedure or condition-specific information and incentives to do this work, that even though they compete in the marketplace, they can collaborate and rapidly improve the quality of care without any measurement to judge or public reporting whatsoever. That we believe that the work that we're doing extends well beyond the common performance measures that you see in the marketplace, and I think it won't be hard for you to recognize that. I'll just give you a little thought to keep in mind. The next speaker is Hatinder Gurm from the BMC Squared Cardiovascular Consortium, and he'll be talking about coronary angioplasty. And imagine a pay-for-performance program. Those are very popular still, though they haven't been shown to accomplish much. And what would it entail? What would it focus on? It would focus on mortality in coronary angioplasty, and it would focus on door-to-balloon time, probably not anything else. When was the last time when you were given your mortality results, you could go and fix them or improve them? It doesn't work that way. It's a very lowest common denominator approach. Contrast that, please, when you hear Dr. Germ speak, with the level of sophistication and rigor and nuance that is brought to the challenge of assessing and improving the quality of care in coronary angioplasty within the context of the BMC Squared project. This slide is just a repeat of the list of the current CQI programs, and I will stop there and ask Dr. Germ to come up and share his project with you. Thank you.
Thanks, Dr. Scher, for the kind introduction. Well, I would like to first of all acknowledge those who started this program. I came to this program fairly recently, and this is the work of people like Mauro Muscucci, Eva Klein-Roger, Dr. Scher, and all the collaborators in the state who have made this program what it is. Over the next 15 minutes, I'd like to focus on what this program has achieved, what it does, and what we learn from it, and what we go back and keep doing. So this program was started 10 years ago. It is a collaborative, and the key word is collaborative quality improvement registry, focused on improving the outcome of patients who are undergoing coronary angioplasty or stenting. This is a collaboration between interventional cardiologists across the state with support from hospital administration and from the Blues with the aim of improving patient outcome. It has successfully managed to do what many thought was impossible. Physicians from competing institutions, University of Michigan and St. Joe's, that are 1 mile apart, we compete for the same patients, yet we will sit down together and figure out how can we help improve outcomes across both institutions. And this is now a statewide thing. In every city, in every county, every hospital that does angioplasty is part of this collaborative and uses this data to improve their outcome. What we do, we collect the data, we audit the data, we rigorously look at the data, we identify problems that can be improved upon, we share the best approach, we learn from hospitals that are doing a good job, then we share this data with hospitals that aren't doing a good job, and then go back and see if they are starting to do a good job. Why do we care? Well, first of all, angioplasty is a very commonly performed procedure. It started in late 80s, and you can see very quickly, it's one of the most commonly performed procedures in the country. The good news is that after crossing the 1 million men mark, the procedure is essentially stabilized. Now there are only about 1.2 million procedures being performed. It's not continuing to grow. So what's the BMC2 PCI registry's goal? Well, we all know that there's a rich data set that identifies what's the best evidence base. We also know that the patients are not getting the best evidence-based therapy. And our goal is simply to bridge that gap. So how do we do that? Like I said, we collect the data, we identify where the gap is the most extreme, we identify how we can fix this across the entire consortium, and sometimes the problems are more unique to a hospital, where the hospital then gets focused data and can then do a local rigorous analysis and see how they can improve this. And then we go back after a quarter, after a year, and see if the hospital's getting better and provide them more feedback in a collaborative fashion again to try and improve the outcome so patients are getting better care. We've also developed fairly sophisticated risk assessment models so that we have a good idea, is this hospital's outcome really related to that they're treating sicker patients, or is it just because there is something wrong here? This is sort of the essential working of a program. Up here is the database, but this is the most important person. This is the nurse coordinator who collects the data, who will then get the report from the database back and take it to the hospital physicians and the administrators. Then these two have to work together to make sure that the necessary steps are taken, so whatever is the problem is fixed, and whatever they're doing well, they keep doing better. These are the 3 phases, but these are not really phases in isolation. So all the time we are collecting data, establishing benchmarks, then using these benchmarks to establish interventions. And then we follow up to see how these interventions have succeeded or failed, and then go back, collect more data, establish new benchmarks, and the process goes on and on. This hospital registry started with 5 hospitals. Currently, every hospital except for 1 in the state that does angioplasty contributes data, and uses these results for their local QI programs. So I'd like to share some examples. I only have 15 minutes, so I can't share all the things that we've done, but I'll just go over a few things which will provide a brief overview of what this program has achieved. So this is a paper that I believe is in your folders and was published by Mauro Moscucci in Circulation in 2006. So what this is looking at is the 5 hospitals that first started the collaborative. These are in blue are the outcomes. These are standard adjusted rates. So this is the outcome before they started, and this is the outcome after 5 years. These are hospitals that joined 5 years later. So it's not that with time things get better. It's really that these hospitals have done a better job of reducing complications, and hospitals that are not in the collaborative are doing worse on all these measures. So this data actually convinced a lot of the hospitals that initially were reluctant because they felt, well, we know the literature. We can use this data. We read our journals. We provide good care for our patients. But this paper and showing this data, sharing this data, and the fact that we were able to do this in a collaborative fashion without making this public, it's not like one hospital is going to present this data and say, we are the best in the state. But instead, if they're better at one thing, they usually are not better at another thing. And we sit together and say, okay, how do we get better? But the key thing has been, well, this is good, but we want to do better. And this improvement, this need to improve further is evident here. So these are all our hospitals. And we're looking at mortality rates that are very low. But low is not good enough. We want to lower this further. So all these are relative reductions. But let's put this in perspective. There are about 30,000 patients getting angioplasty every year in the state of Michigan. So when you look at this reduction in mortality, that's 0.2%. That's about 70, that's exactly not 0.2, but that's about 70 less deaths. That's about 90 less bypass surgeries, about 60 less patients undergoing an emergent stenting, about 2% reduction in transfusion. That's about 360 patients, smaller vascular complication rate, and smaller contrast nephropathy. So anytime we do angioplasty, we give contrast dye. This contrast dye, if you give too much, can shut down the kidneys. May not seem like a big deal, but for us it is a big deal because it hurts our patients. And we've had consistently a reduction in contrast nephropathy. What was the magic thing that we did? Well, the magic thing is we know if we exceed the amount of contrast that a patient is deemed to be safe, once you exceed the level, patients do worse. So once we became aware of that this data is being recorded, look what happened. In the 5 hospitals, the number of patients that are exceeding this contrast limit, the rate drops. As the rate drops, the need for dialysis drops. This is not too hard. Everybody knew this was happening, but now we are so focused. Almost every hospital, every patient that comes in, there's automatically a thought that goes in, what is our maximal contrast dose? Something that almost everybody does in their mind, but once you have a number, it's much easier to follow that number and not exceed that number. Why do we care so much? Once you get contrast nephropathy, the outcome's really bad. The mortality of contrast nephropathy has not really changed over the last 8 years. So up here it's about 20%, and now it's about 16%. But really, tell a patient your mortality has gone from 20 to 16%, well, that's still a problem that's best avoided. It's expensive. Once these patients get this problem, they stay in the hospital 7-8 days. That adds up a lot of dollars for the hospitals, for the healthcare system as such. And different hospitals have a marked difference in how well they do or how poorly they do. So this is the first 3 quarters of the last year. And you can see some hospitals are approaching 1%, other hospitals are up here. Now, I can assure you that by next year, what will happen is these hospitals will move somewhere here, but then somebody else will move up here. Our goal is to push this whole thing down. And we've identified quality targets. So our goal for the collaborative is that the 75th percentile is the upper limit of acceptable. We will not accept any hospital exceeding that. We're going to push all the hospitals less than 75th percentile, and the ideal is the median. We want everybody to do better than that, and we hope we will get there. And the reason I am confident we will, because in the past we have. How do we do this? Well, like I said, we establish our benchmarks. We provide a summary of what's the best standard practice. We provide a summary, which I think hospitals find more useful, is how hospitals that have done better are translating that best practice into actual practice. Like, what have they done that makes sure that the patients are getting the best optimal care, best hydration, don't exceed the contrast dose, what are the steps? We provide online dose calculators. The nurse can, before the start of the case, tell the physician, okay, this is the dose that you do not want to exceed. And when the patient's gotten that dose, they tell the physician, you've reached that limit, be careful. Sites that have done well, we follow them more closely to see that they keep doing well, and that acts as an incentive for them to keep doing better because they want to always highlight, well, we are really good at this. But then we've used their experience in sites that are not doing well, and then introduced sort of more focused root cause analysis, and then sites have usually done, within a short period of time, that their rates come down quite a bit. What has happened across the consortium, as you can see, the rates that were about 3% are now down to about 2.4%, so about 0.5% reduction. So consistently with time, we're seeing more and more improvement. We saw a slight jump here, but this was mainly explained by a newer hospital that joined us. And they made our analysis look a little bad. But we don't want to hide any number. Otherwise, we'd be going down here. But this is our effort is to bring this down to somewhere less than that. Why do we care about this? I mean, why should, these 60 lives saved are very important, but what about the overall healthcare cost? Well, think of this. We said 96 less bypass surgeries. Emergent bypass surgery costs about $100,000. A transfusion, I was surprised to learn, costs somewhere between $2,000 to $5,000. It's not the pack of blood. It's all the testing that goes before. The patient stays in the hospital longer. Then some of them get transfusion reactions. They get other problems, and so on. Contrast nephropathy, there's surprisingly little data to say how much it costs in the United States. In a German study, it costs about $20,000. They provided the numbers in euros, but at that rate, it was about $20,000. Very expensive, and yet small reductions can make a huge difference in the overall cost saving that we can get. A reduction in bypass probably saved the state $9 million. What have we done for the Blues? This is a cost analysis that was done by the Blues. I have no idea what numbers went into this, but they've told us that we have consistently saved them money, and the cumulative saving go up to about $22 million. So our hope is that since about half the patients are Blues patients, other half belong to somebody else, that overall across the state, money is being saved, patients are getting better outcome, and it's a win-win strategy. So I'd like to conclude by saying that dedicated QI can be done with collaboration. Actually, I think the only way it can be done is with collaboration, but it's an ongoing process. It's not like a one-time goal that you can say, okay, we've solved this problem and then we are done. This is really something that consistently requires dedicated efforts that we go on and on and on, requires focus from everybody. It saves lives, it saves money, and I think it's something that we all have to do in every field of medical care. Thank you. So I'll let Dr. Birkmeyer come up.
That's very good. Excellent.
No, thank you.
Tender, thank you. I'd also like to thank Mary Ann and her colleagues at CHART for putting together such a great symposium. I'd also like to give a quick shout out to Tom Simmer and Dave Scher, who I think history will prove as the architects of a very innovative approach to improving quality and reducing healthcare costs. I'm a bariatric surgeon. Very few people know that, but bariatric surgery, of course, for everyone in the audience, is surgery for the intended purpose of substantial weight loss. Many of you are familiar with the gastric bypass. You watch the network news, so you see the direct-to-patient advertising for the lap band. You may even have heard of some of the other new operations that are being done within this field. What you may not know is how commonplace the field of bariatric surgery has become. This shows the total number of bariatric operations done within the U.S. on an annual basis over a period of 13 years. You see that in 1996, fewer than 10,000 of these operations were done. As of just 2 years ago, in excess of 200,000 were done. Bariatric surgery passed appendectomy as the second most common operation on the abdomen in the U.S. Now, what's fueling this exponential growth in the rates of bariatric surgery? Well, it's a variety of things. Part of it is advances in surgical technology, and specifically the dissemination of techniques with laparoscopic surgery. Part of it are successful outcomes for Star Jones and for Al Roker and for Carney Wilson, and you can probably think of a much longer list. But part of it is because we collectively are getting fatter. Now, the obesity epidemic is not news to anybody here, but what you may not know is that it's particularly acute in the biggest of the big. The proportion of the U.S. population that is at least 30 pounds overweight has approximately doubled over the last 25 years. The proportion of the U.S. population which is at least 100 pounds overweight has increased more than 5- or 6-fold over that period of time. So in other words, hey, that's not funny, man. So in other words, the problem is not the guy on the right-hand side, it's the guy on the left. And I don't mean to beat up on Notre Dame, but its head coach, Charlie Weiss, is an unsuccessful recipient of a gastric bypass. Now, despite its rising popularity, there have been many questions raised about the affordability, the safety, and efficacy of bariatric surgery. These questions are not just coming from our professional organizations, but they're coming from the lay media, from regulators, and from payers. In this context, in the early part of 2005, the Michigan Bariatric Surgery Coalition was founded under the leadership of my wife, Dr. Nancy Birkmeyer, who is not a surgeon, but she's a clinical epidemiologist. And just like the model you just heard about from Dr. Gurn, this is a partnership between leaders of Blue Cross and Blue Shield of Michigan, clinician scientists here at the University of Michigan and elsewhere, and surgeon and other leaders at all of the 23 hospitals in the state of Michigan that are involved in the practice of bariatric surgery. Just like the program you just heard about, the CQI program rests on two basic elements. One is high-quality, comprehensive clinical outcomes data, and an explicit platform, an explicit plan for QI at the population level. Now, over the last 3 years, we've been targeting a number of high-priority areas within the field of bariatric surgery. We've been focusing on effectiveness, trying to understand the determinants of good outcomes with regards to weight loss and quality of life, and the successful resolution of comorbidities. We've been focusing on aspects of resource use, and specifically the very high rates of ED use as well as 30-day readmission after these procedures. But of course, our primary interest has been on the safety of the surgery, and I'm not going to talk about anything other than a very narrow slice of that piece of the puzzle. Let's talk about the complication of pulmonary embolism. Most of you already know this, but any person undergoing major abdominal surgery, and particularly persons of size, are at risk of blood clots that form in the major veins of the thigh and of the pelvis that are at risk of breaking off and traveling up to the heart and lungs, causing a pulmonary embolism. This causes at least half of the deaths associated with bariatric surgery here in 2009. Now, there's a variety of effective and fairly standard strategies that are used as prophylaxis against this complication. There's early ambulation to get the circulation going. There are compression stockings. There's the widespread use of blood thinners. But more controversial is the use of IVC filters. IVC filters look like badminton birdies, and they get placed via a large catheter that gets inserted through a vein in the groin. They get passed up and placed in the inferior vena cava. That's the main vein that drains blood from the lower half of the body to the upper half of the body. And the concept here is that it traps those fatal blood clots from traveling from the lower half of the body up to the lungs and causing a pulmonary embolism. Now, their value as prophylaxis is very unclear, at least in the medical literature, but this has not dissuaded in any way their rising popularity. At least 200 to 1,000 of these get placed every year. Their use is growing fast with the new generation of removable types of IVC filters. So, when we looked at our first year's worth of data, we were flabbergasted to see that approximately 10% of all of the bariatric surgery patients in the state of Michigan were getting these things as prophylaxis, maybe Everybody else wasn't, as flabbergasted, but that's something that we never ever did at the University of Michigan. So we tried to get a better sense about how much benefit was associated with these filters in terms of reducing complications and reducing risks of fatal pulmonary embolism. And what we found was not only no evidence of benefit, but actually pretty clear evidence of harm. As you see here, the patients that were getting filters had more than a threefold increased risk of venous thromboembolism. That's the medical term for blood clots. They were 5 times as likely to die, and they were significantly more likely to have other types of serious complications. Now, of course, we ask ourselves, of course, we entertain the possibility that maybe this increased risk of serious complications is not about this device, but it's more about the types of patients that tend to get them. They're being put in higher risk types of patients. Well, it turns out that hypothesis was slain by the data. We looked very carefully at the records of the subset of people either dying or having a permanent disability as a consequence of bariatric surgery. And among those patients with filters, more than half of those incidents were directly attributable to the filter itself. People were dying of a fatal pulmonary embolism even though they had the filter in. The vena cava was clotting off at the site of the filter, or the filter was migrating and propagating and moving up towards the heart, which is generally not good. So that's the implications for patients. What about for payers? Well, it turns out that filters aren't free. And we looked very carefully at the total payments around episodes of care with bariatric surgery in 2006 with the use of Blues claims data. And the average total payment without a filter was $32,000. All patients with a filter, that total payment was in excess of $45,000. So a net incremental cost of $13,000. Now, of course, this piqued our interest, and we tried to drill down and better understand hospital practice patterns with regards to IVC filter. And what we learned was really cool, or maybe not cool, sort of worrying. And that is that our practice patterns vary very widely across Michigan. What you see across the x-axis are the 20 different hospitals that at that time were taking part in our coalition in submitting data. You see on the vertical is the proportion of all patients undergoing bariatric surgery getting a filter. And what you see is that 14 or 15 of the hospitals were putting them in a small number of patients. In fact, 5 hospitals never ever used these things. 5 hospitals were using them in lots of patients, and in fact, 3 of the hospitals, which includes 2 of the biggest and busiest programs, were putting them in more than a quarter of all of the patients. Why? Well, we again entertained the possibility that maybe those 5 hospitals were seeing a disproportionately higher number of high-risk, older and sicker patients, and we really didn't find that. As you see illustrated in red here, those 5 hospitals were operating on patients of similar age, size, gender, and prevalence rates of dysmobility and diabetes and sleep apnea. They did have slightly higher rates of patients with a previous history of blood clots, but this difference was small and way too small to account for the differences in the use of filters. And now let's look at the implications on their outcomes. These 5 hospitals that put in tons of filters, just as we saw with the patient-level data, had a 3-fold increased risk of blood clots, a 7-fold increased risk of deaths, and across the board higher rates of every grade of serious complication. So let me tell you about what we did. Well, let me tell you first what we didn't do. Simmer and Scher did not send a letter to the CEOs of these 5 hospitals saying that their status as centers of excellence was hereby revoked. Those hospitals did not get a letter saying that the Blues would no longer pay for their IVC filters. Arguably, some of you might have thought that that would have been the obvious way to deal with this. Nancy Birkmeyer did not send all of the surgeons a thick packet of practice guidelines and clinical trials and telling the surgeons who should or shouldn't get a filter. And we didn't even out these surgeons at our quarterly meeting. We did almost nothing except show them a bunch of PowerPoint slides. I got up, I showed them slides that are very similar to what you saw, and it was interesting, the reaction of the surgeons. It was basically, those surgeons had no idea that what they were doing were any different from what everybody else was doing. So over the course of a quarter or two, we drilled down into the clinical data. The high-rate surgeons talked to the low-rate surgeons. They eventually appreciated that they could safely do their surgery without the use of these devices, and here's what happened. Rates of IVC filter placement dropped from their historical highs that hovered somewhere in the 10% range down to where they are in this current quarter, close to 2 or 3%. Now, what this means is that in the state of Michigan, that an average of 200 or more fewer patients undergoing bariatric surgery now are not getting filters. And when you do the math, that's an annual savings of $2.6 million for all payers, $1.3 million for the Blues. Now, I saw on the roster here that there's some pretty major healthcare purchasers. I saw the people here from Chrysler and from General Motors. You guys didn't fly here, did you? But many of you are thinking 1.3 million, 2.6. That is a rounding error in my budget, and it's true. But what I want you to appreciate is that number one, this one source of savings pays for our whole program, and number two, this sort of low-hanging fruit adds up. And when you add up all the things you'll hear about from Hitender and from Skip and me and a myriad of other programs, this is real money. So finally, here's my last slides. There's a couple of take-home points. The first is that it doesn't take much for collaborative QI programs to pay for themselves. The return is substantial, and it's many-fold in excess of the cost of running these particular programs. Our MBSC program was not launched with the specific target of reducing the rates of the use of IVC filters. That was serendipity. That was an incidental finding. But just picture what the potential savings could be attached to all of the primary outcomes on, that we currently are focusing on. The second is that there no doubt are healthcare quality problems that will require bigger carrots and bigger sticks. And but what I want you to leave here with is that there's a number of those that don't. And it's remarkable what you can achieve by giving surgeons and hospitals high-quality data and feedback about their outcomes in their practice. Thank you very much. Let me introduce to you our next speaker, Dr. Skip Campbell.
Well, thanks, John. And I, too, would like to thank Mary Ann and Tom and David for their leadership in putting this program together, and also for allowing us doctors to have an active part in quality improvement in the state in partnership with the third-party payer. I think that's really an innovative concept and one that hasn't gotten enough attention. As you heard Mary Ann say, President Obama has been rather direct about his goals for healthcare reform. It's to improve quality and reduce cost. What is not so clear, and particularly in the area of surgery, is what is the best platform to improve quality, which happens to be the first thing we need to do. I'm going to make the case, as Hitender and John have done, that regional collaboration among hospitals is an untapped resource that can be very, very effective. So this is the group that we put together about 5 years ago with the generous support of Blue Cross Blue Shield. And it has, we call it the Michigan Surgical Quality Collaborative, and there are 34 hospitals in this collaborative that each individually submit 1,500 general and vascular surgery cases to our database every year. So that comes up to about 50,000 general and vascular surgery cases a year that go into our MSQC server and can be analyzed at any time. So the three elements of our collaborative that are important are that we use a standardized reporting format, which I will talk about, the National Surgical Quality Improvement Program. We use this information to share information, and this partnership with Blue Cross Blue Shield, as I mentioned, has been a very important part of our undertaking. So this, in a nutshell, is what we do. We collect surgical quality data, as you heard. From that data, which allows us to compare surgical results, we identify who we think are the best performers. And when we find hospitals that we think are the best performers, we go into those hospitals and we try to find out why they're doing so well, and we develop what we think are the best practices in this area, and then we share that information among our members and anybody else who wants to listen. So that's a very simple sort of algorithm for our quality improvement. So the first and very important aspect of our collaborative is that we need to be able to compare apples to apples. And we use what is arguably the gold standard in surgical outcomes reporting. We call the National Surgical Quality Improvement Program, which was developed about 10 years ago by Shukri Khoury in the VA system and is widely touted as one of the best contributions the VA has made to modern quality improvement. But as opposed to using administrative data, which has a lot of deficiencies to it in order to measure quality, the NSQIP is prospective and uses standardized definitions. And nurse reviewers are trained in those standardized definitions and tested with yearly inter-rater reliability tests and audits to make sure that they are accurately recording complications that are defined by the NSQIP. Importantly, we use defined endpoints, and in surgery it's much easier than in some other medical specialties to do this. We do an operation, and we'd like to know what happens 30 days later. Did the patient live or die, or did they get a complication or not? And NSQIP has defined 22 separate complications that might happen after any surgical operation, and each one of these complications has a very specific definition. And finally, there's a risk adjustment model that has been validated on multiple occasions and allows us to level the playing field and account for differences in patient comorbidities at different hospitals. So the NSQIP is the gold standard, and it exists in 240 hospitals nationally. It's sponsored by the American College of Surgeons, and 34 of those hospitals are in our state. So how do we use this data? This is a typical slide that we would show at one of our quarterly meetings, and I'll explain what this slide shows. On the left side of the graph is a percentage. Now, this particular graph is unadjusted data, but we also use risk-adjusted data, showing the percent of patients that have an SSI. That stands for surgical site infection or a wound infection. Now, obviously, patients don't have that when they come into the hospital. They have to have an operation to get this. And so it's definitely a hospital-acquired infection. So on the x-axis are the 34 different hospitals in our state. And we're measuring this complication. In this particular case, it's wound infection rates in clean cases. Now, non-surgeons, clean cases is a definite type of case, the most uncomplicated kind of case that we expect to have a very low wound infection rate in these clean cases. So there's this spectrum of performance in terms of developing a wound infection in a clean case, and it ranges from almost 5% of the patients down to none in some cases. And the question that we like to ask is, when we look at those hospitals that have very few wound infections, why is it that they have few wound infections? And frequently, as John mentioned, we'll go into a hospital and they'll say to us, well, we don't really know, but we seem to be doing very well. So it takes a concerted effort to pick apart the various process measures that are important so that we can define them and transport them to other hospitals. And then on the other side of the graph, there's a little red box on top of the results from other hospitals where they're struggling. They're not that they're bad hospitals, but they're struggling in some way or another. And so these hospitals are identified as well. And the way our system works, every hospital, at the time we present this data, every 3 months they know the identity of their hospital, but they don't know the identity of any of the other hospitals. So it's possible to go into the best performing hospitals and pick apart at what we think they're doing well. Now, the second aspect of this analysis, however, isn't such a granular analysis, but it's an analysis of what are the characteristics of the hospitals that consistently perform well that are possibly different from the hospitals that consistently seem to have troubles. And that is something that we're currently very interested in, and that also might be portable to hospitals that are having difficulty. So it's the very granular and the very global kinds of analysis that we like to do. So when we go into these hospitals, we have an executive committee, and we sit around and decide what it is that we think were the best practices in these well-performing hospitals, and then we make a list of them. And in this case, this has to do with SSI prevention, the wound infection prevention worksheet. And we have 10 very granular kinds of process measures that we decided were important. Did the patient have a preoperative shower or not? Was the initial dose of antibiotic based on weight? As John mentioned, we have many big patients in this state, and it's important to have the right plasma levels, but typically surgeons and anesthesiologists don't think of that. Everybody gets 1 gram of Kefsol. So what about, are they redosed with antibiotics if the operation lasts longer than 3 hours? Well, that's important too, because as you know, plasma levels and tissue levels fall off if you don't redose. But as we look throughout our state, it turns out only 10% of the hospitals actually have a protocol to redose patients with antibiotics at 3 hours. Can we avoid a blood transfusion? Was the skin prepped with ChloraPrep? There's some good data out there that is better. And so there are these 10 or 11 different items that we thought all of the hospitals ought to know about and remind themselves about. So we put together in a sheet like this. On the left side, you see what I just showed you, the wound infection rate in clean cases, and this is the wound infection rate in a different category, a little more complicated category called clean contaminated cases. And the idea is to take this and put it right in the face of the surgeon or the nurse who's about to do an operation. And I think, did I skip that? It didn't show up for some reason. I'll show it to you in a minute. But so anyway, that's the most important part of what we do. Get this information to the surgeons and the nurses, and while they're washing their hands, let them think about it, and it's sort of like a pilot's checklist. So the partnership with Blue Cross Blue Shield of Michigan is very important, and I think something I'm very proud to be part of. And the idea that we collaborate is based on something very important, and that is the idea that we're in a pay-for-participation environment here, where every hospital is paid or reimbursed for participation in this group using the same standardized formula. So it's not a pay-for-performance kind of measure. The problem with that pay-for-performance kind of measure is that it tends to develop and generate competitiveness among hospitals, and they don't feel quite as willing to get in a room like this and talk about their bad results or their good results for fear of losing out financially. So most of the costs of the participation in NSQIP, in fact, all of them, are reimbursed by Blue Cross Blue Shield as part of the program, the hospital incentive program that David pointed out. And David also mentioned that Blue Cross Blue Shield only sees aggregate data and has never asked for anything more than that. So one of the guiding principles of having a collaborative like this is it's got to be a friendly and collegial group. People have got to be willing to trust enough so that they can stand up and say, well, I'm really having a problem with this particular aspect, and what is somebody else, what are your suggestions as to how we could improve this? And I just showed a couple of pictures here in our quarterly meeting that we have in Blue Cross Blue Shield environment, and we have lectures, and then we have lunch, and these folks are sitting around a lunch table, and we usually try to put some sort of topic at the lunch table. Those of you who are interested in thus and so will sit at this table, and this is not going to go over well for those of you who are not general surgeons, but in this particular table on the left, the topic was bowel prep prior to colon surgery. And so I'm quite sure that would be probably unappetizing to most of you, but we're general surgeons, and that is something that we're very, very interested in. So how do we collaborate? The idea is quarterly meetings at Blue Cross Blue Shield. We have an audience response system. So this room looks very much like the one we have our meeting in, and you would always be sitting there with a clicker, and I can ask 10 or 20 different questions that are of interest to the whole group and get the response from the audience within seconds. And that's a very important way of understanding what the practice patterns are. We developed our own MSQC website where we enter data and we can show the results of our work, and we can post slides from previous presentations and important articles, and we can have a sort of blogging environment. We also have a hard copy MSQC newsletter for the electronically challenged, and we just recently started having a YouTube site, which was stimulated from a thought from my sons, and they encouraged us to use this, and now somebody can sit at the bus stop and look at their iPhone or whatever and get an idea in 10 minutes what the best practices. The first one we ever did had to do with colon surgery, and one of the surgeons who had done a very good job and had great results, I said, you have 10 minutes to tell the rest of us how you get such good results, and he did it, and so it's on YouTube. And then finally, of course, we use email to collaborate as well. So now, this is all well and good, but the question is, do surgical results actually improve after time with this kind of open philosophy? And the answer to that is yes. And it was an important thing for us to find out. So we looked at this is kind of a complicated slide here, but we looked at what we call the O to E ratio, that is the observed to expected ratio for wound infection, for all sorts of complications, in the MSQC on the left-hand side of the graph, and the NSQIP on the right side of the graph. So we were able to talk to the American College of Surgeons and get the identity of the MSQC hospitals and separate out the hospitals that don't participate in the MSQC. And we put this in the form of a statistical process control graph. But the point is that on the left side here, where you can see the O to E ratio for morbidity in the MSQC cases, they basically dropped over time, and these red dots indicate a rule violation, which means that this is a special cause variation as opposed to a common cause variation in the MSQC experience, and this the x-axis shows time over here, whereas we did not see that in the NSQIP over that same time interval. These are the non-Michigan hospitals. So this kind of information allows us to draw the conclusion that something special and different is happening in this regional collaborative as opposed to the national experience. So does that save money? Well, as John just gave a good example of how it does, and we found the same thing. I will use a different example than the IVC filter, but this is an example of a very sick individual who may or may not develop what we call ventilator-associated pneumonia. You get an idea of the degree of complexity of some of the patients we take care of in modern surgery. And the ventilator-associated pneumonia is really a nasty complication, and it's thought that it happens when a patient is intubated, as you see here, and there are all sorts of little organisms in the nasopharynx that might or might not get through the endotracheal tube and end up in the tracheobronchial tree, and depending on the host resistance and so forth, may get this pneumonia, which can be devastating and very lethal. But it's an expensive problem, and I put this picture of an automobile here because I know how much that car costs. I have one. I just bought one last year, and it's the best car I ever had, so I'm very happy that I got it, but it wasn't cheap. So this cost of $55,000 is approximately what the incremental cost of a ventilator-associated pneumonia is, and we've looked at that very carefully in our own experience. So if there is a baseline surgical expenditure of about $5,000 for an uncomplicated case, add $55,000 if that patient gets a ventilator-associated pneumonia. So it's not a cheap item. So when we looked over at our results overall in the MSQC over basically a one-year time period, and the TP1 refers to time period 1 and time period 2, about a one-year time interval, there were 35,000 cases in the MSQC database during that period of time, and there was 300,000 or so in the non-MSQC hospitals. And you can see the relative performance over time here, that we saw very substantial reductions in the incidence of sepsis, septic shock, pneumonia, prolonged ventilator status, and wound infection, as well as cardiac arrest requiring CPR. So those were pretty dramatic improvements. They also had sort of an infectious respiratory theme to them. But we also looked in the non-MSQC hospitals, and there was some improvement too. Nationally, there was some improvement, but it didn't seem to be as much, and it wasn't statistically as much as we noticed in the MSQC. But focus on this one number here, that the pneumonia rate went down by about 30%. And then there's this back-of-the-envelope calculation that could easily be done. We had 34,000 patients in the MSQC, and mind you, this is just a sample of cases in the 34 hospitals in the first place, and then there are 100 and some hospitals in Michigan, so it's not all the hospitals. But there's 34,000 cases. If we had an incidence of VAP of 2.42% in time period 1 and 1.69% in time period 2, that means there were 823 cases at the initial time period and 575 cases later. A difference of 248 times $55,000 is $13 million. So that's just for one complication. Now, it tends to be a very expensive complication, but the NSQIP measures 22 different complications. So if one extrapolates to, widely to many different complications, as John said, these are real numbers. And more pays for our program. And so I think that's a very important point to mention. Now, we also did some calculations, which I won't show you, but if we extrapolated this data and said that the 120 hospitals in Michigan, and we knew how many general vascular surgery cases were done in Michigan from the Michigan Hospital Association gave us that data, and then did another extrapolation just in terms of preventing ventilator-associated pneumonia, and I admit that there's some big ifs here, but if we could achieve the same sort of performance across the board in Michigan, it amounted to $140 million a year just for this particular complication. So that needs to be studied more. But it's also true that I know that the Keystone initiative that MHA and Blue Cross Blue Shield have been very involved in the prevention of bloodstream infections, which was another sort of collaborative that was estimated to have saved $160 million across the state in the prevention of bloodstream infections. So I think these numbers are big numbers, and you could argue about exactly what the number is, but I think the point is that it's very important and achieves our goal of saving money at the same time that we're improving outcomes. So I'll stop by saying that this collaboration is relatively unique in the country, I think. It's between Blue Cross Blue Shield, the American College of Surgeons, and our 34 hospitals. I was just recently in Tennessee, where there are 11 hospitals that have used this model with the Tennessee Blues and the Tennessee Hospital Association. There's also one that's forming in Virginia. There's another one in the Excellus program in Upper New York State. The Illinois chapter of the American College of Surgeons is starting a collaborative. All of these are based on the NSQIP and based basically on this model. So I'm hopeful that as time goes on and we are able to demonstrate the effectiveness of these kinds of collaborative programs, that it will take off in other areas of the country, and we may be able to talk the government and the new Obama administration into incentivizing this kind of development of collaboration across the country. So again, thank you for coming, and thank you for allowing me to speak about this subject.
Before we shift into the questions and answers, I wanted to do just a little bit of translation on what you heard today and how we think it can relate to the healthcare reform debate at the national level. I think you heard tremendously powerful examples. You saw just a sampling of these collaboratives. We didn't have time to show you all of them. We have hospital and physician leaders across the state who are participating in these efforts and really achieving astounding results. You know, in healthcare, we have a tendency to demonize those when we look at the issue of healthcare costs and healthcare spending. And having spent 20 years of my career at Blue Cross and Blue Shield, I can say I'm probably as guilty as anybody in looking for a silver bullet, a one situation, an outlier here or there, a simple solution to the healthcare problem. There is no silver bullet. And though I think we would all agree that there are certainly bad actors, there are individuals who perform poor quality, that we must deal with fraud, we must deal with abuse, those in and of themselves, we know, are not going to fix the issue with healthcare spending. They are not going to get at the core problem of why we spend so much more than 40% more in this country relative to other countries who do have universal coverage. What we are finding in healthcare, what we should know about healthcare, is that we are talking about systemic issues. We have known for 30 years about variation in healthcare from one community to another. Our colleagues at Dartmouth have done a terrific job in highlighting that variation. We've all looked at the data of what Miami looks like versus what Minneapolis looks like. We've known that information for years. And yet we've had great difficulty in translating that knowledge into change in behavior. What we see here is the ability to make that translation. And there are several factors, I think, in these kinds of initiatives that are truly fundamental to that translation and are really sometimes ignored, overlooked by those in search of quick and simple answers. Everybody spoke about it when they gave their presentation today. This information is confidential. This information is shared on a peer-to-peer basis by practitioners. The Blues don't have access to individual hospital information. The public doesn't have access. Now, we tend to be very focused these days on public reporting, on public report cards. We know, however, there's a lot of problems with those public report cards. They don't really change consumer behavior. They do get lots of people's backs up, and they're often inaccurate. This information, and I think it was, I can't remember whether it was Skip who said it well, or John or Hitinder, but this information is being shared among clinicians who are truly committed to change. And they use it without that fear of being penalized in some way when information is shared. And so what this is doing is getting to systemic issues. We've talked a lot among ourselves, and I'm surprised Skip didn't bring up the whole policy of never events. And if you look at this week's New England Journal of Medicine, you will see quite a defense of the policy of never events. And I will go out on a limb and say I think it's a wrong-headed policy. Now, is it the right thing to do? Are there systemic issues that need to be changed? Is it an important area of focus? Yes. Does it get at the reasons why these never events are occurring? No. It's a system of punishment and of fear. It's not sharing data. It's not improving outcomes. It's not improving practice. This focuses on improving outcomes, on improving quality, and it gets the results. Now, what does it take? It is a more complicated system. It's much more difficult to explain publicly. Never events, in fact, if you read the article, I loved Arnold Milstein's article in the New England Journal this week. It was great because he made the statement that the phrase never events is a political phrase. Everybody gets worked up about it. Everybody relates to it. It's great marketing. Quite honestly, collaborative quality improvement, that's not the most memorable phrase. It's kind of complicated, and it's had multiple names, and we won't even go into what BMC squared actually stands for because we keep forgetting. These are more complicated processes, but they're better. They're better for patients. They're better for the system. They take committed clinicians. They take data. They take funding. They've taken leadership. In our state, we've been tremendously fortunate because we've had the leadership from Blue Cross and Blue Shield. The fact that Blue Cross and Blue Shield covers half the state's population enables it to engage in these all-payer initiatives. That's a tremendous bonus we have in Michigan that doesn't exist elsewhere. We have much more fragmented payer systems elsewhere that make it very difficult to do something like this. We have that great leadership in Michigan. We've had great leadership at the University of Michigan Health System. It was Morrow who came forward with this idea to begin with. Other leaders have followed, and other leaders in other hospitals. Beaumont Hospital is leading one of these collaboratives. The MHA is leading a collaborative. I know we have colleagues here from those organizations, and truly, every hospital has come to the table with a goal to improve quality. And so it takes that kind of support. It takes financial support. This is not cheap to do, and it can't be done on the cheap. If you look in your packets, there's a chart in there that tells you a little bit more about every collaborative, and we put in there the cost of the collaborative to Blue Cross and Blue Shield, what they have expended. They have spent millions of dollars on this initiative. The returns have been even greater. Returns in money to customers and the returns in quality to patients have been even greater. And you see those savings in that packet. You see that information. All of this is public. It's all transparent. But it takes that kind of sustained commitment. It takes financial support. You heard from all of those who spoke about these collaboratives, it takes staffing. You need to pay for the staff who do this work. It doesn't happen unless there's focus. And so you need those nurses. You need the clinical leadership. You need the administrative support. You need the data. You need that coordinating center. That has been a conscious focus of all of these efforts. So they are more complex. They're multi-party. We think this is the kind of thing that we ought to see in healthcare reform. And if we really want to shift the curve, it's going to take efforts like this. Systemic change over long term, focused on improving quality, not just going for what is a good consumer soundbite. So we thank you for coming and for hearing about these initiatives. We do want to open it up to your questions at this point, and we have mics if you want to just raise your hand and speak up. Again, if you want to write your question down on a card, Pam, over there.
Yeah, I don't have a question. I have a comment and a request. And as background, and it relates to your comments, as background, let me tell you, I've been involved in this reform debate since 1974, and I wasn't 4 when I started. I recently picked up a copy of a Kaiser Family Foundation study, and I recommend that all of you go to their website and look at it. The study really blew me away. It was a study looking at health professionals' perspective on concerns around quality versus the public's perspective on concerns around quality. And the bottom line is the public has very little concern about the quality of care provided in the United States. The reason that's important is we are about to go into a congressional debate about what falls into the framework of health reform. And so one of the issues we have is how do we as professionals bring the quality issues into that debate? And I would love, Mary Ann, for you to follow this excellent seminar up with something related to looking at this challenge between a public perspective and professional perspective on this issue. Because if we don't address it, quality is going to be the stepchild of reform.
Right, and for those of you who didn't hear Pam, let me just repeat in brief your conclusion, which is that there is this incredible disconnect between how the public views quality and how we and the professionals view quality. And the public, and I think all the polling data, Pam, you're right, shows that the public thinks they get good quality. And of course, they use different measures maybe than clinicians would to measure that quality. And how do you bridge that disconnect as we go into this national reform debate is going to be very, very fundamental. You're absolutely right. And thank you
Glad
for
to
that.
work with you, but I have to leave, so I apologize. I
Oh.
wanted to get that on the table.
Thank you, Pam. And I should have said, by the way, at the outset, for those of you here in the room, all of the presentations are on our website. You can download and print them at your leisure, so we hope that you do take advantage of that. Thank you. Yeah, go ahead, Ron.
I appreciate Pam's comments regarding quality. I think along the same lines is when we talk about reducing cost, I think if you approach the general public today, you would be hard to find anybody who sees any of our efforts reducing cost from their question or their perspective in terms of affordability. So while we're debating with the feds how this might be integrated into some national plan, there appears to also be, I'll say, a messaging, a marketing opportunity with the general public. Just what do we mean in reducing cost? Because we recognize the need to remain private for fear of retribution and the like. But if this message doesn't get out to the general public, or when it does and they hear reduced costs, they're going to say, well, how come my bill is not going down? So I think that's a caution as far as working the public sector with the feds, but how do you communicate this to the general public as well?
Yes, that is a challenge. Ron's point being, how do you communicate this cost to the public and the importance of these kinds of efforts on cost? And again, we know from polling data that when consumers talk about wanting to lower healthcare costs, they're talking about lowering copays, deductibles, premiums that they pay, not the costs that we're talking about today. Now, of course, to make universal, what we're focused on is to make universal coverage affordable at the national level, at the state level by businesses. We've got to lower the total cost, not just, but it is a challenge on communication. I have a great question here that I would appreciate, and then I'll come back to you, Gil, that I appreciate everyone on the panel addressing. And it's your perspective on what do you see as the top 4 reasons for the dramatic rise in healthcare costs over the past 40 years? You have 4 reasons. And if anyone can start who wants to jump in.
Can I start with just one?
Yeah, you don't have
And
to have 4. Maybe we'll get
for-
4 collectively.
For those of you that don't know me, I'm relatively new to the University of Michigan, at least only 4 or 5 years, which makes me new. But I came from Dartmouth, and I was one of the editors for the Dartmouth Atlas of Healthcare. And I read with great interest Atul Gawande's article that was in the New Yorker this past
Yes.
week, which gave
Glad you
a lot of shout-outs to some of my former buddies. But he had a great quote in there, which I thought captured a lot of the reasons for escalating costs, which is not directly apropos of what we're talking about here, but it's that physicians became businessmen rather than physicians. over time. And I like to think that that's not a phenomenon that is prevalent in this room or at the University of Michigan, but when you look at the phenomenon of variation, and not just variation in technical quality, but variation in the use of healthcare services, there is no doubt that the entrepreneurial aspects of healthcare have had a lot of positive benefits for society, but there also is a pretty ugly downside of that. And I hope that as Collaborative, that we broaden the scope of what we're doing over time to not only deal with what this panel was talking about, which was optimizing technical quality in the outcomes that are conditional on a decision to operate, but also on the quality of decision-making and of the choices that we all make about who gets to surgery or gets to the hospital in the first place. And I appreciate some of the work that you're doing in that area, Mary Ann, but I think that there's a lot of work to do there.
Skip.
Well, I would maybe just add to what John said, that I like this phrase, the marginal use, I mean, the variable use of marginally effective treatments. That to me says it all in terms of the cost problem that we have. And I think that these collaboratives are in a good position to address some of these issues. One of the things that I didn't have time to mention it, but one of the things that we're looking at in our MSQC collaborative is this issue about how a person is evaluated who is approaching surgery but has a history of a myocardial infarction. How should that be evaluated properly? Is it nothing, or is it a 64-slice CT with interventional angiography after that? And I think we're in the process of trying to develop that information. And similarly, post-operatively, if a person has a little troponin leak indicating some degree of myocardial ischemia, how should that be dealt with? There is really no standard. The evidence is not out there. And it can be a very expensive evaluation, depending. So I think one of the roles that the collaboratives can have is try to, first of all, define what the variation is, and then try to put together a consensus document on what the standard of care is in our region, or should be, and then hold people to that. And I think that would help.
David?
Well, 4 sounds daunting. I'll just try 1. And that is, I think that as a society, we have an over-reliance on technology to solve human problems and health problems, and an under-reliance on primary care and the human dimension of self-caregiving and seeking guidance from health professionals. And that really speaks to John's point about the decision-making process, about what care we need, what care we seek, what care we choose to get. And I think that it's one thing to make the procedures that are provided better, more efficient, more effective. That's essential. But it's more important to address the fundamental questions about what are the best approaches to addressing human health problems, and to what extent are non-technological approaches superior in adding value to a life. And I don't think we as a society or as a community of healthcare professionals keep that concept in mind adequately.
Tom?
Again, I'll limit it to far fewer than 4. I think over this period, there's been a huge expansion of the availability of very expensive services that have potential to help people. And we have not designed the system to create a high-performing healthcare system that uses this tremendous expansion in a judicious way. And I think it really goes back to, we've got to be more proactive about designing a high-performing healthcare system so that we can benefit from these technologies rather than, as Skip was saying, use them in marginal cases or even in cases where the use of this technology produces more harm, such as the IVC in bariatric surgery.
And I just want to add one, or really, it's not adding one, but really synthesizing some of what others of you have said, and that's so well illustrated in John's piece on the IVC filter. We have inadequate regulation in our country when it comes to new technology. And if you look at what the FDA is doing with regard to procedures, devices in particular, the focus is on safety, not on efficacy. And if we simply change that, there's a lot of discussion right now on comparative effectiveness research, which is really important. It's great stuff to do. But if we just focus on changing the way the FDA looks at devices, we would look at that IVC filter differently before it got into widespread use and was marketed by the manufacturers. Gil?
Thanks. Another cause, of course, is unhealthful behaviors, what Johnny Carson would call the 4 biggies of guns, cars, alcohol, and smoking. I wanted to ask you all, this is tremendous and impressive and really shows the value of collaboration and systemic change in a region of the country. It's nationally with SCIP's consortium. There are 2 components of the present national effort that are already jump-started. One is big investments, incentives, and later penalties about electronic health information. And the other is comparative effectiveness research, which Marianne just mentioned. I'm curious, of the kinds of things you are already doing and planning to do, how much of it do you think would relate to capturing low-hanging fruit under the rubric of comparative effectiveness research, and how much of it would benefit from greater installation of health IT and its appropriate training and testing and utilization?
Skip?
Well, that's a great question. I think with regard to the comparative effectiveness research, one vision I have for the MSQC is the development of not maybe all 34 hospitals, but maybe 10 hospitals that are interested in participating in randomized controlled trials. And getting a grant of some kind from the stimulus package that would allow us to embed trained nurses in terms of carrying these things out at 10 community hospitals so that we could address the really simple but unanswered questions that have to do with our specialty. So I think that's really what I'm looking for in terms of that. Now, in our area with regard to the IT infrastructure, that part of it is not the choke point for us right at the moment. We've got a great way of electronically entering the data. We can make the data collection easier using natural language processing and a standardized H&P. That's kind of what I'd like to see with the American College of Surgeons. It would advocate a standardized history and physical, electronic history and physical that would have NSQIP definitions built into it so that the data collection becomes a part of the workflow and not something that a nurse has to do additionally. And if that could happen, I think then everybody could evaluate patients in exactly the same way. And then, as we talked about this morning in one of our surgical conferences, at the end of the history and physical, when all these NSQIP definitions are built into the history and physical, what pops up on the computer screen is what this particular patient's spectrum of risk is for surgery. And when that happens, what are the elements that we could do that might mitigate against this risk? And I think that's, to my way of thinking, that's the next IT advance that we should use.
John?
Sorry, I can address a couple of the things. I totally agree with Skip that the greatest relevance of HIT with regards to some of the things we're talking about is its potential to help us scale up what we're doing now and make it much less expensive to gather high quality data and to feed it back for the purposes of improving quality and lowering costs. Comparative effectiveness, evidence-based medicine. I'm not quite as bullish as the administration and everybody else. I believe that in isolated instances like IVC filters and a few other things for which better evidence could clearly guide therapy, I think that there's a lot of potential gain here, but I'm very brainwashed by my Dartmouth days and appreciate that there's a lot of unmeasurable variation that is related to differences in how we incorporate patient preferences and physician practice style into what actually happens at the end of the day, that evidence-based medicine is not going to totally fix the problem of variation. I think that there's a couple other things that Obama et al. Are working on that I think have the potential to offer real gains. As you know, one of them is not only better EHIT, but also its relationship with the idea of the primary medical home. And I think that discoordinated care is one of the root causes underlying the wide variations in the rate at which people tend to get hospital care and certainly different types of surgical interventions. And then finally, I think that one of the less publicized priorities of the new administration is better aligning incentives of hospitals and physicians. We at the University of Michigan tend not to focus on this because we all get our paycheck from the same places, but in most of America that is a real issue. And I believe that within the next 12 months or so, there's going to be very explicit, very tight bundling of hospital payments and physician payments and home health and a variety of other payments that go around episodes of hospital-based care that will really make the hospitals and the physicians be much more thoughtful about the financial implications of their quality and their practice style.
Tom?
My answer would be that neither of those components that you mentioned in and of itself will have an impact on healthcare costs. They both entirely relate to how we use them. For electronic medical records, if it is considered an electronic access to information useful in the care of an individual patient, I don't think it will have any impact at all. If instead it becomes the vehicle by which we do much better population management and we actually know how to access components of care for purposes of clinical process improvement, and I think that that was really at the heart of Skip's comment related to how information is put into those records to be retrievable, not just for the individual patient's care, but for a broader purpose. And I think the same thing's true about comparative health technology. If we do use that, like they use it in the UK, to determine what gets covered and what doesn't covered on a national level, and it actually folds out into our choice of which technologies that we use on a day-to-day basis in healthcare delivery, then that would achieve significant healthcare savings.
Actually, if I could, let me just add a couple of thoughts. Certainly having sophisticated information technology will make it a lot easier and cheaper to gather data for many consortia-based, registry-driven quality improvement efforts of the sort we've heard about today. I think, though, that more importantly, building the learning from these sorts of efforts and from other sources of evidence-based guidance into information technology in the form of clinical decision support that would both support proactive population management, as Tom was mentioning, but also individualized care at the point of service. I think that that's really the potential strength. And so most of the EMRs I'm familiar with don't really contribute much of anything except a lot of process change, but they have that potential. With regard to comparative effectiveness research, I'm not an expert in that, but my sense is that the basic model that's used is a very academic one, and the populations that are studied tend to be highly selective. So it's kind of a rarefied look at a narrow application of technology. One of the beauties of these sorts of projects is that you have an opportunity to do highly sophisticated, albeit somewhat empirical, examination of the relationship between process and outcome with various technologies or non-technological approaches to care in free-range populations, not so highly selected. And I think that's, the reality is that the vast majority of application of technology we're concerned about happens not in these highly selective populations, but we extrapolate from learning done with those to the general population, and oftentimes that's a poor connection that intellectually and in practice. So I think there's tremendous potential to use these kind of projects and approaches for comparative effectiveness research.
Samson Wade. Oh, I didn't want to go. Please go
I
ahead.
want to just say one little thing. I think the focus on electronic medical records is a little misplaced unless they are used to help improve patient outcome. I think if it's just going to replace a paper record, it's useless, or it's just another expense. But if we can, for example, figure out this patient is hypertensive, this patient's cholesterol is high, this patient's a smoker, and we can automatically alert the doctor that these levels are above goal and fix this, and then that information is used to improve patient outcome, that will be a big step. Otherwise, it will be just another bureaucratic hassle that practices will have to leap through.
Go ahead.
Thank you. Marianne, congratulations, a well-done program. I think the center's timing is spot on as we're right in the midst of this debate. I think about another article that Dr. Uwande wrote a couple years ago about the checklist highlighting the activities here in Michigan in bloodstream infection prevention, and there's been a great deal of conversation about why not just mandate. And I think the point should be taken as I reflect on Dr. Campbell's time frame of his data on SSI reduction and kind of a similar time frame that we went through our experience in Keystone. That was the time frame in which another state was implementing mandatory reporting. And about the time those results were completed on both Dr. Campbell's part and in his collaborative and ours, they were ready to report. Meanwhile, there had been dramatic change here in the state of Michigan, which calls to point the need for a voluntary effort to energize the providers to do the work in a very cohesive manner. And just a second comment is I think the vision that Blue Cross has demonstrated as a payer to invest, recognizing that those returns don't necessarily come right away, and they're quite honestly very difficult to measure. As all of us have seen, it's hard to get to those numbers. But as we look at the federal government's desire to use takeaways and maybe some givebacks as a method for incentivizing, which I would argue is not. So thank you, well done.
And we should note, Sam heads up the Keystone Center, which is another one of the collaboratives, so we're happy that you're here.
Actually,
Wanna
could I
comment?
respond, Sam? Thanks for bringing up the subject of public reporting, because I'm all in favor of empowering patients, but there's not much evidence that patients actually take that information and act on it. It really is something that sort of prods providers to do things that'll make them look good in public reporting. But I wanted to share some research that was done by the BMC Squared collaborators. And what we did is we teamed up with folks from New York State who had a similar clinically rich data set, and we applied the same risk adjustment models. And we looked at the outcomes in coronary angioplasty in Michigan, which didn't have public reporting but did have the BMC Squared project, and in New York, which did have public reporting and didn't have anything like this, and over the same time period. And the unadjusted data showed that the mortality rate in Michigan was considerably higher than in New York State. The adjusted data showed that they were identical. So the outcomes on a risk-adjusted basis were the same, very good in both states. The fundamental difference is that in New York State, far, far fewer, several times fewer proportionately, patients with heart attacks and heart failure received angioplasty than in Michigan. So many more people who were at high risk and who had a real potential to benefit from these procedures, but also had a potential for complications from these procedures, received them in Michigan than in New York State. The analysis was blind to where those patients went. They went to the medical wards. So they weren't dying as angioplasty patients if there were complications. They died as medical heart attack patients in the CCU. Or going back home after, the 30-day mortality rate is not examined. So my point being that public reporting isn't just sort of a nice thing but benign, that actually there are potential unintended and adverse consequences that are quite serious and really alter the whole trajectory of care in a community. And so again, pointing in my mind to why this more robust approach, really clinically rich approach, achieves a lot more net value than what I think of, lowest common denominator approach of public reporting or pay for performance, which look very narrowly at just a few aspects of care.
Tom has one comment, then we'll go.
I think that there's, or did you want, did you say?
Go ahead,
Okay.
finish your comment.
I think that there's a role for public reporting, and then there's a role for collecting data for improvement. And when you look at these programs, how much confidence do you have in going to an organization for care that is not participating in some sort of collaborative improvement? By the time we would have reported who had the high IVC rate, they wouldn't have had a high IVC rate anymore, because they're part of a dynamic process by which discovered opportunities to improve care lead to those improvements in care. So if you separate those things that are data collection for the sake of process improvement from data collection for the sake of reporting, I think you do find that there are elements that fall into both categories appropriately. But I agree that when you mix them up and do it the wrong way, that what you get is unintended consequences and not particularly better choices and more informed choices by the people seeking care.
Okay, how about one more here, and I do have a couple in writing I want to get to before we close, so go ahead.
The question, I think, about the last 40 years is a very challenging one. I happen to have been lucky enough to work through all 40 of those years. In fact, a few more. And I think back to when I started working in healthcare, what was healthcare? If somebody had a heart attack, they came to the hospital, they looked at them, kept them warm, talked to them, that's it. None of the technologies we talk about today that we were looking at today even existed. Now, assuming our research capacity is not going to go to zero or slow, I think our biggest social question is, what is health care and what is going to be covered by any form of broad-based universal coverage versus what is not going to be covered And I think David shares point about what is our responsibility as individuals to just to take care of ourselves. Those, I think, are the serious questions, because if we're going to try to pay for everything our research people can imagine, there is no money, not enough money in the world to pay for it. There's no country in the world that pays for all known technologies for all people today. And I think it's only going to get worse. So I think we have to look at what is it that is going to be considered fundamental health care? What is the person's responsibility to take care of themselves? And what is going to be truly afforded only by the rich?
Those are very important questions and absolutely a great statement about where it is we need to go. Thank you. So 2 questions, and I think more of a statement than a question, right? So 2 questions here, and then we'll close it out. First of all, there is a lot of interest in how the data collection works. Can you address, any of you, can you address the issue of standardization, costs? Many sites participate in multiple registries, resulting in redundant data collection efforts, and I think that is one of the attributes of this effort, because it is an all-payer data registry. So maybe any one of you can talk a little bit about how the registry works and how you standardize. You all want to.
I wasn't hoping to answer this question because it's a very complicated process. There were procedures by which data get collected very widely across just these 7 programs, not to mention the processes by which data for the SCIP program and all of the other reporting needs of the hospitals get met. We've tried to be as thoughtful as we can within these 7 programs that are funded by the Blues to make sure that there's a minimum of redundancy. It's a very costly process, as you know, depending on which of the registries we're talking about. The cost per patient of the collaboratives you've just heard about is somewhere on the order of about $100 a patient, which is not a trivial amount of money. Only a small portion of that goes to the research side of the enterprise or its coordination. It's mainly about the costs of clinical personnel that are looking through charts and filling out forms and sending them in to the University of Michigan or to Beaumont. I think as we look to the future of that process, I think that there's a couple of things we need to do. The first is we need to make better use of information that's already gathered for other purposes in electronic form and make sure that person time isn't being used for gathering that sort of information. I think the second thing that we need to do is make sure that there's a minimum of waste. We're gathering only exactly what is needed to accomplish our ultimate goals. And then finally, we need to look for ways to make sure that the process is streamlined to the point where data get gathered by personnel that are already involved in the process of clinical care. I think that the model by which there are dedicated FTEs that do nothing other than abstract charts and submit data ultimately is a flawed one and is one that's going to be very difficult for us to scale up elsewhere.
I think, John, I would agree, and I think what I would like to see happen is a more national focus, perhaps from the Joint Commission, on outcomes rather than what they focus on now, which is not necessarily outcomes. And so I think a lot of the redundancy and hard work that goes into trying to meet all the expectations of various government agencies could be bypassed if it was known that a hospital had very good results in one particular area, but that's frequently not asked. And so we were talking in one of our meetings this morning, our infection control meeting, about the national patient safety goals, and they're very detailed and labor intensive. For instance, do we document that a patient's to patients what our hand hygiene protocol is? Is that told to the patients at some point, and do we document it? Well, that's a lot of work to do that, but I think if we just looked at, for instance, our bloodstream infection rate and found that it was very, very low, why would we need to do some of these things? And so I think a more outcomes focus would be something that I would advocate.
Great. All right, you want to comment before we do last question?
Yes, I do. So it's true that it is costly and complex. You can see, I think, that the return on that effort is substantial and positive. Some of the projects are incorporating web-based approaches to data gathering and submission so that it's a much more streamlined process, and actually people can use those tools in the course of providing the care. So it's not all data collected after the fact by somebody not involved in care. Some of the projects do include approaches that basically integrate the data gathering effort with existing clinical information systems, for example, in catheterization labs. And then there are efforts across some of the projects to coordinate the data gathering effort with national registry data database efforts so that there isn't redundant work, or at least that redundancy is minimized. So the data elements are in common and the data are gathered once and then shipped out electronically to 2 sites when the hospital has to report or chooses to report to more than one site. So yes, it's complex and it's an effort, but there are ways to make it more efficient. And ultimately, with really comprehensive electronic information systems, links between those and data registries of this sort will become automated, and one day we'll be, we won't be talking about data coordinators as a funded position. We'll be funding people who are doing the work of process change more, or just simply having more resources available for that.
Tom wants
I just want to say it beats PQRI.
Yes. Not everybody knows what PQRI is, but I assume a number of physicians here do. Last question, I think, for David or for Tom. You've sparked interest in folks who want to start a collaborative. And so how do you choose which collaboratives? We've got 8 or so going now. How do you choose the topic areas, and how does somebody give you the ideas to start a new one?
He pointed to me first. Basically, we're looking for areas of care which, for these types of projects, which are technologically sophisticated, where the technology is evolving, where we don't know what is the right approach to practice. There's a lot to learn, where there's enough complexity and cost to warrant the investment, and where there exists interest in the provider community in coming together to examine in common the link between process and outcome, learn about what works, and apply it. So there have to be some folks who have the intellectual expertise and clinical expertise and a health services research perspective and a population perspective. This isn't a research project we're talking about, it's a quality improvement project, but it's very rigorous and it uses the same kind of intellectual tools. So you have to have someone or a group with that sort of tool set and motivation to be willing and able to lead a program. And so, you can imagine that there are some areas that are begging for this sort of attention, back surgery, hip replacement, knee replacement, but it's not easy to find the folks in those areas of care who are ready and willing. And so we establish relationships with institutions and with professional societies, and we engage in dialogue, and we see what bubbles up as an opportunity that fits those criteria. And then when the conditions are ripe, we move forward. So it's not a formal process. It's more of a, you're going to love this year in Ann Arbor, it's an organic process.
But if you're interested, talk to Tom or David afterwards, and we'll see if there's an opening here. And all the speakers will stay afterwards. Thank you all very much for attending, for participating. We are... Great job. We will have an evaluation form online. We're going to send you an email to ask you to fill it out. Help us with our own quality improvement and our future areas of focus. And I do want to say a special thanks to the staff for the Center for Healthcare Research and Transformation. You can raise your hands. A lot of work to put this together. They did a great job. Thank you all for coming. Thank you for your input.